and we will begin with Dr. Walensky on your opening statement.
Good morning. Chair Murray, Ranking Member Burr, members of the Senate Health Committee, I appreciate the opportunity to join you to provide an update on the COVID-19 pandemic and the impact of the Omicron variant. It has been just over 2 years since we were first alerted to the emergence of SARS-CoV-2 in China. And since that time, CDC has worked with our partner agencies and you in Congress to take remarkable action to protect the health and safety of Americans. Omicron is now the dominant variant in the United States, driving case counts to unprecedented heights here in the United States and around the world. Despite the increases in cases, there are promising emerging data from South Africa and the United Kingdom that hospitalization rates for people infected with Omicron are lower compared with prior variants. These data seem consistent with what we're seeing so far in the United States. However, despite a potential decrease in severity, the substantial number of absolute cases is resulting in hospitalization increases across all age groups, including children aged 0 to 4. The emergence of the Omicron variant again emphasizes the importance of vaccinations and boosters, which decrease the risk of infection, severe disease, and death caused by COVID-19. Just last week, we made important progress towards increasing booster coverage through four key actions. First, we expanded eligibility of booster doses to those 12 to 15 years old. Second, CDC strengthens its booster recommendation for adolescents, now recommending that adolescents aged 12 to 17 years old should receive a booster shot 5 months after their initial Pfizer-BioNTech vaccine series. Third, we recommended that moderately or severely immunocompromised 5 to 11-year-olds receive an additional primary dose of vaccine 28 days after their second shot. And fourth, we shortened the recommended time between a primary mRNA series and a booster dose from 6 months to 5 months. Each action increases access to vaccines and booster doses at a time when protection is critical. As we continue to monitor this rapidly evolving virus, we are working quickly to adapt with it. Over the holidays, CDC updated our quarantine and isolation guidance, first for healthcare workers and then for the general public. I know this update has resulted in numerous questions, so I would like to take a moment to walk through it now. For people who tested positive for COVID-19, CDC recommends isolation for 5 days. If you are asymptomatic or if your symptoms are resolving, for example, you're without a fever for 24 hours, you no longer need to isolate. However, you should continue to wear a well-fitting mask at all times when around others, including at home and in public for an additional 5 days. We recommend that you avoid activities where you are unable to wear a mask and that you avoid travel for the full 10 days. In addition, CDC changed the recommended duration of quarantine. Quarantine is what you do after you're exposed. People who are not up to date on recommended COVID-19 vaccines should quarantine for 5 days if they come in contact with someone with COVID-19. People who do not develop symptoms by day 5 should get tested. If you test positive, you should begin isolation. People who test negative may end quarantine and should continue to wear a well-fitting mask when around others for an additional 5 days. These recommendations are consistent with over 100 studies collected over the past 2 years, indicating that people are most infectious during their first few days of infection and significantly less infectious 6 to 10 days after infection. A core part of CDC's mission is to translate science into recommendations for best practices and real-world circumstances. Over the holidays, we saw the growing surge of Omicron and took swift, science-based action to address the very real possibility of staffing shortages in hospitals and in other essential areas of the workforce, including schools, pharmacies, public safety, public labs, grocery stores, and other sites, where shortages could have and have proven to have dire public health consequences. This is the right guidance for what we currently know about transmission and the real-world circumstances we currently face. As we will learn more, we will continue to update accordingly. Omicron is likely not to be the last curveball this virus throws at us, but we have the tools to prevent further spread of this virus. This means for everyone 5 and older, please get vaccinated. For those 12 and older, get your booster shot. And please continue to adhere to the multi-layered prevention measures, including masking and, yes, washing your hands. Thank you, and I look forward to your questions.
Your clock and stay within those 5 minutes. As the Omicron variant of COVID-19 continues to spread at an alarming rate, people are looking for clear, straightforward guidance on how to protect themselves and those around them. It is really critical that we reduce the infection rates so we can relieve pressure on our healthcare workers, protect people with disabilities and older Americans, young kids, and anyone else who's been disproportionately impacted by COVID-19. However, I have heard from so many people who find the latest CDC isolation and quarantine guidance confusing and hard to interpret. So Dr. Walensky, can you please clearly explain CDC's latest guidance on what people need to do to protect themselves and others if they are exposed to or contract COVID-19? And let me start with vaccinated people. What is your guidance to them?
Thank you, Chair Murray, for the opportunity to clarify. Maybe if I could just rewind the clock to just before the holidays, where we were hearing from hospitals that their staff were going out and that they were in a real crunch in terms of beds. They had plenty of beds, but they didn't have staff to staff them. ICU beds were starting to close. So immediately we worked towards our updated healthcare worker guidance. But when we did so, we recognized that we were going to have challenges and that this Omicron surge that we were about to face was threatening many other places of our healthcare sector.
I appreciate the background, but I just want to know, straightforward, if someone is exposed to or has COVID-19 and they're vaccinated, what do they do?
If they are exposed to COVID-19 and they are completely boosted, they do not need to stay home, but they should get a test at day 5. If they have COVID, our guidance does not distinguish between your vaccination status. And our science has demonstrated that you're maximally infectious 2 days before and 2 to 3 days after. So by 5 days after your symptoms, if you're feeling better, if your fever is better, if your cough and sore throat are better, then on day 6, you can go out, but you have to wear a mask. You have to wear a mask reliably, and you should not go to places you can't wear a mask. You probably shouldn't go and visit grandma. You shouldn't get on an airplane.
For vaccinated, what about unvaccinated?
Same for unvaccinated for isolation. So isolation being those who have had disease, who have disease.
Okay. Well, let me just say, nearly 2 years ago, when this committee first started having congressional hearings on COVID-19, the very first thing I asked was, where are the tests? And we've made progress.
To ask you a question about access to testing, and in particular, what is the CDC doing to make sure that testing capacity is robust in rural America and also among community health centers in disadvantaged parts of the country?
Thank you, Senator Kane. So we have this program, Increased Community Access to Testing, in collaboration with ASPR as well. This is a program that has collaborated with FEMA to increase surge testing just over the holidays. We've increased federal testing sites for PCRs, 12 federal testing sites doing thousands of tests over the holiday. We also work with pharmacies. This is a collaboration with pharmacies. And in that stead, we are able to map where the pharmacies are and their social vulnerability index, and we can actually put PCR tests in areas of high social vulnerability index through all of our pharmacy partners, CVS, Walgreens, Rite Aid, and whatnot. And then we actually put tests in our community centers as well. So really a broad stretch in order to be able to get access to testing, especially among those most vulnerable. And then, of course, as Asper O'Connell mentioned, $10 billion for testing supplies to our schools, and working closely with our schools in peer-to-peer support, in technical support to allow those tests to be used well in those school settings. Thank you.
Thank you for that answer. And Dr. Fauci, one more question for you. I
want to take my time to just do a little bit of an update on best practices for schools. I know we talk about this a lot here, but part of what I think is frustrating for a lot of parents is that the guidance they're getting from their schools changes. And I get it, educators are sort of adjusting as the variant changes, as technology changes. But what has changed since the last time? Has anything changed since the last time you were here about what you were recommending for schools to stay open? I appreciate what you said in the last hearing, is that schools should be the first places to open and the last places to close. Man, as the parent of two public school kids, I couldn't agree more. The trauma on these kids during this pandemic has been significant, and the data tells us that especially for poorer kids and kids of color, distance learning just doesn't work. I'm grateful that I've got a governor who's gone to extraordinary lengths to make sure that the federal dollars are used to keep schools open. But anything new that you can share with us about what you're recommending for schools to stay open for the rest of the year?
Thank you, Senator Murphy. And in fact, you took the words right out of my mouth. Schools should be the first places to open and the last places to close. We had a Delta surge in the fall, and 99% of our schools were safely opened. And one of the things that's majorly different between September of 2021 and today is we have pediatric vaccinations. We have vaccines that are available for every child over the age of 5, and the children who are in the hospital now are largely those who are unvaccinated. So first and foremost, one of the most important things that's changed is we should be getting our children and our teenagers vaccinated. And if our teenagers are eligible, we have boosters available for our teenagers as well. So we saw through the Delta surge that we were able to keep our children safely in school before we had vaccines. So now today, what do we have for our children? We have vaccines, of course, that we can use. We have school testing programs. We have new science that demonstrates test to stay. This is where a child might be exposed in the classroom, but if they're exposed, they don't have to stay home in quarantine. They can test every other day or twice a week and stay in the classroom safely. And what that has demonstrated is hundreds of thousands of person days of children in school rather than at home. We have new science that has demonstrated the value of masking. 3.5 times increased risk of school outbreaks if you're unmasked in schools versus if you're masking in schools. And just this week, we updated our K-12 guidance so that it is consistent with our isolation and quarantine guidance for the general public, so that people can come back to school after isolation after 5 days.
Thank you, Dr. Walensky, for that and for your commitment to keeping our schools open. Final quick question for you, Ms. O'Connell. Talking about in-home.
Secretary O'Connell is in a good position to follow up, and I would like to follow up after the hearing, but I did want to ask one other question to Dr. Walensky. We've long had problems with accurate state vaccination data in New Hampshire. It's come to light that the CDC's data on New Hampshire's vaccination rates is also inaccurate. Apparently, the CDC can't consistently distinguish in its data between first doses of the vaccine and boosters. And as a result, the agency incorrectly records boosters as first doses, artificially raising the vaccination rate. The CDC's data is inaccurate for other states as well. We've been looking at this for other states too. So what steps is the CDC taking to resolve these data inaccuracies? And when will the CDC have accurate data for New Hampshire?
Thank you, Senator. This is a really important question. So CDC is the compiler of the data, and we rely on the state immunization services to provide CDC the data at the state level. Now, among the challenges with these accuracies is that if people don't bring in their card, they are counted as a first dose when in fact their card would have been a third dose, and we rely on the states to work to reconcile any differences if a person put in a middle initial on one card but not on another. And we're working closely with every single state to increase the accuracy. We're encouraging people to bring their cards because that also increases the accuracy. We recognize this challenge, and we are working state by state, including in New Hampshire, to reconcile these inaccuracies to get them more accurate in our comprehensive reporting of every state.
Well, I appreciate that very much. Thank you, Madam Chair. I'll just say that what I'm hearing you say to the general public is it's really important to help with the accuracy of data by keeping your card, taking a photo of your card, making sure that you're sharing all your information at the site where you're getting a vaccine or booster shot.
Very helpful, yes. Thank you very much.
Thank you.
Thank you. Senator Marshall.
President Biden here.
Ask tough questions, but we are not going to allow this committee hearing to be another personal attack that undermines our.
Thank you. Thank you, Chair Murray, and well, I'll just let that go. So as we move into the third year of the COVID-19 response, it seems to me that our strategy is shifting. We are shifting from a goal of trying to get to zero COVID cases to eradicating the virus. And our goal is really much more about minimizing the damage of this pandemic. You and I have talked about this, Dr. Fauci, as well as with Dr. Walensky. So we need, of course, to minimize hospitalizations and deaths caused by COVID. We do that through vaccines and through therapies. We also need to minimize the COVID damage by understanding how to keep kids in school, how to keep businesses open, and how to protect against the damage that is caused by social isolation and burnout and other stresses that injures our mental health. It seems to me that while this is happening, while COVID continues to seriously stress our healthcare system, and while we still have people in this country, including, sadly, some members of Congress who continue to spread misinformation and lies about the pandemic. So it seems like we have to be realistic that these cycles of the pandemic, until it becomes endemic, are going to continue. We're going to probably continue to see some unpredictable variants arise. Madam Chair, I just want to say that I hope that this committee can find some time to discuss these issues as they relate to global vaccine strategy, because this is going to be crucial to our work to protect Americans' health as we go forward, since we are not an island. But let me ask, I'm very interested in how we think about like the data that is important for Americans to keep in their minds as they're trying to measure relative risk. Last week, public health experts published some interesting articles that suggested that we should maybe think about incorporating COVID-19 data into aggregate risk for all respiratory viruses that are circulating, including the flu and RSV. And that maybe this data, if we could look at it in real time from medical facilities and ERs and so forth, testing facilities, private homes even, would give us a better picture of what's happening. So let me ask Dr. Walensky and Dr. Fauci, if you could talk a little bit, I want to understand about this. I want to understand how you think about this question of relative risk, how we should be transitioning and what we consider, from daily case counts, for example, to looking at other data, and particularly how you evaluate this idea of looking at all respiratory illnesses in one basket.
Yeah, Senator Smith, this is such a critically important question. Thank you for raising this. So we have to do two things simultaneously. Right now, we're dealing with an Omicron surge where we have the most number of cases we've ever had in a day in this country. And so we have to get out of this Omicron surge, but in the meantime, we have to look down the field and we have to understand, what is this going to look like when we're not in a surge? How do we deal with endemic disease, and what do we start looking at with regard to endemic disease? And you're absolutely right. We need to think about the severity of that disease, because now with 62% of Americans vaccinated, some of that disease is not as severe as it was. That's a success of our vaccines. We have to look critically at hospital capacity. What can our hospitals handle? Because if people are coming in with COVID, or if hospital staff are out with COVID, that's a really important measure that we're going to look at. And one of the things we probably still are going to examine, although perhaps with less import, is the actual number of the cases. And why that's important in general is because it generally foreshadows what's coming into the hospital. So knowing that and understanding what that might mean for the future hospitalizations, future severity, future capacity. And all of those are things that we're looking at right now. But one of the things that you critically mentioned was our efforts in data monetization. How do we take the efforts that we've had so far with COVID and increase them, continue to keep the pedal to the metal, as it were? When we started here, we were not collecting racial and ethnicity data. We didn't have a way to link in a personal, with personal identifiers removed, electronic health records with our testing records. We had 187 hospital systems who could do that. Now we have 10,000. So what we really need to do is scale up our data monetization efforts and do it, as you say, not just for COVID, and not just for other respiratory diseases like flu, RSV, as you note, but for all diseases. So we're looking at doing this for maternal mortality, for sickle cell disease, for opioid injury, for many, many diseases. And this is going to be the power of our data monetization efforts, and I'm really grateful for resources from Congress to be able to leverage those. Thank you.
Thank you. Madam Chair, I believe I'm out of time, but I'll
Walensky, it's been reported by some virologists and scientists that this year around 170 people have died from taking the regular flu vaccine. The Vaccine Advisory Adverse Reporting System reported that the number of people dying after or following the COVID vaccine is actually in the thousands. Now, this is what I'm hearing. I'll give you a chance to refute that or confirm it here. You know, is this true? Are we having that many people die after taking one of these vaccines?
Senator Tuberville, thank you for that question. The Vaccine Adverse Event Reporting System is a mandatory system of any adverse event that happens after being vaccinated. So if you get hit by a car tragically after getting vaccinated, that gets reported in the Vaccine Adverse Reporting System, the VAER system. So the vaccines are incredibly safe. They protect us against Omicron. They protect us against Delta. They protect us against COVID. They don't protect us against every other form of mortality out there.
Do we keep numbers of people that died following taking a COVID test from taking this vaccine? Do we have any idea? I'm just asking.
I'm sorry, those who have died after taking a
Died
COVID
following
test?
taking the vaccine. Is there any number count? Do we keep records on that died of just from?
Absolutely, yes. I couldn't give you the absolute number off the top of my head, but our staff could absolutely get back in touch with you. We collect those data.
You know, Dr. Fauci, I'm in rural Alabama, but I get one of these home tests and I test positive.
That gets
I
counted.
understand that. Yeah.
And every one of those is adjudicated.
Yeah. One quick question before we get through here. I'm in rural Alabama, but I get one of these home tests and I test positive. I have asymptomatic. What do I do? People call up, what do I do? I don't have a doctor around. What do I do?
Thank you. So you're asymptomatic?
Pardon?
You're asymptomatic, no symptoms, feel well.
Yeah.
You stay home for 5 days, and the next 5 days, if you continue to be asymptomatic, you can go out, wear a mask. Don't go traveling, don't go to gyms, don't
But I
go
get real
restaurants.
sick, then what do I do?
Then, well, first you go and call your physician. And in fact, I'd say you call your physician regardless. But call your physician, call your provider. If you're continuing to have symptoms, then you stay home until your symptoms resolve.
No therapeutics.
Well, that's where I would say call your physician and see if you're eligible for therapeutics.
A lot of these people don't have physicians.
And
They've got a drugstore.
Senator, we do
Thank you.
need to move on.
Thank
you. Senator Rosen?
Be happy to do that.
Thank you. I appreciate that. I'd like to talk a little bit again. People are talking about the public health data. You know, we're noting about all the daily statistics, we're noting about some of the statistics about possibly death. And so positive or negative, critical, this data is critical even for us to make our decisions as far as what we fund. And sometimes there's notes to say that we shouldn't include home testing in the daily statistics because they may not be reliable. So Dr. Walensky, to build on some of that testing and the statistics that you need to do your job, that all of us need to do our job, how is the CDC working with the state, local health, our hospitals, to be sure that the voluntary self-reporting guidance it is going to be accurate and give us the kind of statistics we need going forward?
Yeah, thank you for that question, Senator. So we are routinely reporting PCR tests. That is what is routinely reported from the state, and that is what our updated statistics are. There's passive reporting that occurs with rapid tests, but I also want to understand the importance of rapid tests, at-home tests, for people to be empowered to use these rapid tests to do the right thing. So regardless of whether we can count them, generally they tend to be people who have milder symptoms. They might have been vaccinated, have a runny nose, and they decide to go and get a rapid test and do the test at home. Less important is counting that case than it is that that person stay home, isolate, do the right thing, and not before transmitting. So I think that many of these tests have different purposes, but one of the really important purposes of these rapid tests, even if we don't count them, is to empower the public to do the right thing through this pandemic.
Thank you.
Thank you very much.
Senator Romney?
Dr. Walensky, good to see you again, and appreciate the chance we had to speak earlier this week, or last week rather. As I've looked on the CDC's COVID tracker report, I note the data goes through November 20th, and I remember my days in business. If we didn't have daily information, we couldn't make good decisions. And I wonder, do we need to invest in either developing a new sub-agency or a task force to get basically on, immediate data, daily data so we know what's going on? And that's not just for the public, that's for those of you who are making those decisions. Do we need to do a much better job moving faster, getting data?
Senator, first of all, let me thank you for your earlier comments, but also to comment on our COVID data tracker. I think you're speaking to the 27 jurisdictions that we now compile data that allows those jurisdictions to report together their testing data, their cases data, their immunizations data, their age data, as well as their death data. It's over 2/3 of the country that we do, and we update that about once a month, and it's about 3 or 4 weeks in arrears. So mid-January, we will be having data through the end of December, and it simply does take that long for our jurisdictions to compile those data, and of course, our death data are generally lagging. It takes a while for those to get reported and adjudicated. So we're now updating those. They're about 6 weeks in arrear, and we're working hard to keep those in real time.
Yeah, I know retailers like Zara, for instance, they apparently get data and correlate it daily. So I'd hope we could find a way to increase the speed with which we get that data. I know my time is up. I'm just going to make a comment, and that is that I think it'd be helpful if people knew when they should get tested, when it's called for, because I think a lot of individuals, myself included, get tested when there's no indication that I need to get tested, other than just want to make sure I'm not sick. And there's huge demand for tests, which are in short supply in part because of that. And number two, when you say when people have been exposed, please let us know what it means to be exposed. We're in a room right now. I'm sure someone here has Omicron. Are we all exposed and therefore need to get tested? What does it mean to be exposed, and when do we need to get tested? I know that I wanted to ask that of Dr. Fauci. I can't do that given my time.
Senator
Those are
Romney,
topics I'd love to have
Senator Romney,
elaborated
I
on.
think
Thank
that
you.
is a question we all want answered, and I will give Dr. Fauci the opportunity to respond to that.
Dr. Fauci?
Be right in terms of the definition of exposure. In terms of who should get tested, you should get tested if you have symptoms of COVID-19. If you do a rapid at-home test and you continue to have symptoms and that test is negative, you should do another test or get a PCR. You should get it tested within 5 days of your exposure, or after 5 days of your exposure, with the definition that Dr. Fauci mentioned. And we're testing through test to stay and other mechanisms as well. So many reasons to test, but really most importantly, if you are exposed, if you have symptoms, and also if you're going into a setting where you might be seeing an immunocompromised person, somebody who's vulnerable, not able to be to take a vaccine.
Thank you very much. Senator Casey.
Thank you, Mr. Chairman. Madam Chairman. It says a lot about 2021 when the most appreciated gift under the Christmas tree in our family was COVID kits for everybody. I'm still getting thank yous for those. Dr. Walensky, there has been a lot of discussion here today about some of the confusion with guidance and just some very clear asks to tell us what that is. So a question that I'm going to forward to you from a teacher is if the teacher is fully vaccinated, boosted, tests positive for COVID, but after they test positive, they feel pretty fine. There's no fever, there's no nothing. After 5 days, can that teacher return to school without testing negative, just so long as that individual wears a mask?
Yes, thank you,
Great.
Senator.
That's exactly what I needed to know. I'm going to be having a meeting, Zoom meeting later this afternoon with several different Alaska-based companies that have more than 100 employees. They're quite concerned about the mandate that requires testing of unvaccinated employees. We all know that this is under litigation now, and things may change on that, but right now their real concern is if this goes into place and we are required to ensure that these unvaccinated individuals receive testing. Right now, testing all around the state is in limited supply. The front page of the Anchorage Daily News shows the line of cars that are waiting to get their PCR tests. You can't find the at-home tests available in the stores now. It is it is becoming harder and harder. And then again, if you really do have a mandate in place, it's going to require this. So I know that the question has been asked about what more is being done. I know we've heard the extraordinary federal resources that have gone that way, but the facts on the ground remain that we are in an extraordinarily short supply of testing, whether it's the at-home kits or whether it's the ability to get the testing that you need. It's cold back home right now, and my hearts go out to those workers who are working in the outdoor drive-in, where they have to go out when it's 20 below, as it is in Fairbanks. That's more of a statement rather than a question there, but I think it is important for folks to realize that we're still in a very difficult place when it comes to accessibility. Dr. Walensky, this is a question for you, and you and I have had many conversations last year about the specific impact of conditional sale orders as it relates to the cruise industry. That industry was effectively shut down for all of 2020, and we were able to salvage a bit of it as things relaxed last year. But in fairness, the industry itself has undertaken extraordinary precautions as one industry to make sure that people are protected from this virus. So the question to you is, I want to make sure that Alaskan communities and businesses can have a season this coming year. And right now, people are making their decisions as to whether or not to book a trip to Alaska for the summer or not. I understand the conditional sale order is set to expire in a few days in recognition that the companies have practices that adhere to or even exceed the guidance in the order. So I guess I'd like some assurance from you that they can count on that this is clear guidance and messaging to those within the industries and to those who are counting on being able to have a season this coming summer.
Yeah, thank you, Senator. And I think the conditional sales order and the fact that the industry has stepped up and is now interested in doing and exceeding, as you note, the compliance with the sale order without the order even necessarily needing to be in place is a real testimony to how well that has worked and how we've worked collaboratively with the industry. What I can say is that, just over the last 2 weeks with Omicron, we've seen a 30-fold increase in cases on ships during this season because of Omicron. So while I anticipate that with ships following conditional sale order, we still will continue to do the oversight and watch and do all the technical assistance and support in every single way. We anticipate that this order will not be renewed and that the cruise ship industries will continue to understand that this is a really safe practice for those industries. What I can't predict is what the summer will bring.
Understand that, but for right now, you expect this guidance to stay in place.
That's my anticipation.
Thank you. Thank you, Madam Chairman.
Thank you, Senator. Thank you, Senator Baldwin.
Thank you, Madam Chair. I want to thank all of our witnesses today, and I also want to just underscore the preface that our colleague Senator Romney gave to his questioning. I like the way he described it. Sometimes we come to perform, sometimes we come to be informed. And I guess I would just speculate a little bit beyond that. If there were to be a true tit for tat on the performance angle, there's any number of areas we could go. I reflect on proposals for ultraviolet light and drinking bleach and drinking hydroxychloroquine. We could go there, but it's not constructive. And so I'm going to be constructive in my questions, and I just urge my colleagues to do that. We're all in this together, and we have a duty to act responsibly in that fashion. And again, thank you to our witnesses. Dr. Walensky, I'm going to start with you on a topic that I bring up frequently when you're in our presence, and that is the tools we have now to sequence, do genomic sequences, to better understand variants, to better track variants. I know that there's been much investment in that. I'd like to hear what tools that we have in place now that we didn't before, and what you see the future of this genomic sequencing is, especially as this committee looks at pandemic preparation for future potential pandemics.
Thank you, Senator Baldwin, and for your championing our ability to ramp up our genomic sequencing efforts, and the resources from the American Rescue Plan, $1.7 billion, really did allow us to detect Omicron swiftly. So maybe I'll just tell you the story of what happened with Omicron, and that is we heard about this variant that was coming from South Africa, and we didn't know if it was here yet. But we did know it had this unique footprint of the S gene target failure on PCR. So what we did immediately after hearing about this is to enhance surveillance for this footprint and do enhanced sequencing so that any sequence that had this footprint, I shouldn't say any, many sequences that had this footprint, we were specifically looking for this Omicron variant. Within days, we found it. So within 3 days, I think, that we started doing this enhanced surveillance, and then within days we had, 10s, 40s. By about 4 days later, by December 5th, is when we started detecting it in our background genomic sequencing. So that background genomic sequencing now does tens of thousands of sequences a week. It's a collaboration with academic partners, industry, commercial labs, CDC labs, public health partners to do tens of thousands of sequences a week. And what we do is we look at the number of cases that are out there, and our goal is to detect a variant that is present at 0.1% with 99% confidence, so that we see the menu of variants that are out there. We are enthusiastic about this program. We are intending to ramp up this program for potentially other viruses, the potential to do so there, for other foodborne outbreaks, as well as for wastewater investigation. We have the capacity to do that there as well. So again, thank you for championing this effort, which truly did allow us to detect Omicron in real record speed. Thank you.
Thank you. Thank you, Madam Chair. Dr. Walensky, during our last hearing, we discussed the critical need for my Biopreparedness Workforce Act legislation that I introduced with Senators Collin, Rose, and Murkowski to strengthen our outbreak response workforce so that we can better prepare for the next pandemic. This legislation would address the serious workforce shortages and recruitment challenges that you mentioned by establishing a new loan repayment program focused on encouraging students to pursue careers as clinicians and biopreparedness health professionals. As this committee assembles a package of policies to respond to the next pandemic, it's important to remember that without people, there is no preparedness. In the midst of the Omicron surge, it has never been clearer that we need a robust and capable workforce to fully respond to public health emergencies. The Biopreparedness Workforce Act would go a long way towards that goal. So Dr. Walensky, as an infectious disease physician and public health leader, can you share more about how a strong clinical and public health workforce is key to responding to outbreaks, and how legislation like the Biopreparedness Workforce Act is important to prepare for the future, public health emergencies?
Yes, thank you, Senator. There's so much here. So first, let me just say, there's been a recent study that has demonstrated that our public health workforce is now down about 80,000 jobs. So just to give you a sense, and that's public health workforce, that's not physicians who are actually doing the work on the ground, right, in the hospitals. This is a public health workforce down 80,000 jobs. We saw through this pandemic the challenges in sort of the volume of people who were doing public health work, but also where they were located and their experience. We need an upskilled public health workforce. For example, we need people to do those genomic sequences. We need genomic epidemiologists. We need people who are diverse as diverse as the communities they serve. We also need to make sure that they are compensated to have the right salaries and, as you say, have loan repayment for their work. To give folks a sense, the infectious disease physicians are among the lowest paying physicians in hospitals. They don't do procedures, and by virtue of not doing procedures, there's not a large incentive from a financial standpoint to continue to go into infectious diseases, which are the bread and butter of what outbreak investigation and clinical it does. There have been many resources that we're moving forward to expand our public health workforce. Public Health AmeriCorps is a big piece of that, and that is something that we're working on and really grateful to resources from Congress to be able to do so. But there's a vital need now to expand our public health workforce in laboratory capacity, in genomic surveillance, in disease outbreak investigation, and a workforce that is upskilled and as diverse as the communities we serve. Thank you.
Thank you. We all know that vaccines remain the best way to protect yourself against existing variants. Senator Casey.
Thank you, Chair Murray. I want to start with Dr. Walensky. Doctor, as you know, the CDC has been working with my staff on an outstanding nursing home vaccine data request. I would appreciate it if you and your team would continue to work with me and with our team at the Aging Committee to resolve this matter.
Yes, thank you, Senator. I'm aware of that matter, and we are committed to continuing to that work with you. Thank you.
Thank you. Let me turn to a matter for Health and Human Services Assistant.
Senator Smith.
Thank you, Madam Chair. I'd like to ask a question of Dr. Walensky, if I could. I think we all know that Americans need better access to rapid testing, and this is a big deal for us in terms of trying to figure out what are our health risks, how do we protect ourselves, and how do we also go about our lives. And I think that we are making headway here, that we have a long way to go. Dr. Walensky, I'd like you to talk about this issue of how we should be, or not, collecting and analyzing the data from rapid home tests. Should we be incorporating this data into, should we be trying to capture that data? Is this important for local communities as they're trying to make decisions about masking and other public health strategies that they want to deploy? Should we be thinking of the data from rapid tests as a tool for individual risk assessment or as an important tool for population level understanding of what's happening? How do you see that?
Yeah, thank you so much, Senator Smith. So we have been using the PCR test, not the rapid test, the lab tests, the molecular tests, to really capture our case counts and really get a good view of where we are in terms of the epidemiology, anticipating what was going to be coming into the hospitals. But the self-tests are a really important, valuable tool for people to empower themselves, their own health, to not expose themselves to other people, to get some information about their own health. And so if an individual were to test positive, if they're feeling unwell, they should certainly consult with a healthcare provider, consult with a pharmacist and your health department. But if you're feeling well, then use that rapid test to say, okay, my test was positive, I need to stay home and isolate, protect myself from the community, protect myself, or the community from me, and protect me, my loved ones so that they don't get infected themselves. And I think that it's less about the absolute case count of understanding whether you have asymptomatic infection or a runny nose and your rapid test is positive than it is really about empowering you to do the right thing and not be forward transmitting.
And could you talk a little bit about what other countries are doing? Are other countries trying to incorporate this rapid testing data into their population metrics? How is that working in other places around the world?
Some countries are and some countries aren't. London and UK have been doing more reporting of rapid testing, but they too are saying that they're missing, I think, somewhere around 40%. I'd have to confirm that number, but they too, while they capture more than we have tried to, they also agree that they're missing some as well.
Okay, thank you very much. Madam Chair, I'm going to cede back the rest of my time.
Thank you, Senator. Senator Hickenlooper.
Great. Thank you, Madam Chair. And again, thank each of you for your public service. Dr. Walensky, I wanted to talk to you just for a moment about genomic sequencing. Even before COVID-19 appeared, Colorado made a genomic sequencing of diseases a high priority, and we're now I think one of the leading states in detecting changes as they evolve in COVID-19. We test about 15% of all positive COVID tests. I think that's still one of the highest rates in the country. And we also monitor wastewater for community detection. So Dr. Walensky, how would we, or how can we expand genomics surveillance and expand those capabilities in order to try to stay ahead of existing but also future threats, COVID-19 or otherwise? How do we close the gap between the states that are heavily sequencing and following this and those that aren't?
Yes, thank you for that and for your leadership in Colorado in genomic sequencing. As I've mentioned, we need to have both numbers and breadth and geographic distribution in order to get a real good view of what's happening in genomic sequencing. So we need to sample from state labs, so we get samples from every single lab. We also get samples from commercial labs, which gives us a lot of volume. We have partnerships now with 19, I believe, academic medical centers in order to do so. And what we do and power our genomic sequencing is so that we are able to detect a sequence that's present at less than 0.1%. So we scale up, and based on the number of cases that we have, we scale up or scale down our genomic sequencing so we can detect it. And what we were able to do with Omicron is when we saw the footprint of the S gene target failure in PCRs, a similar footprint as alpha, we were able to do targeted enhanced surveillance of sequences that actually had that initial footprint and able to identify sequences even before they reached that 0.1% threshold. So as you said, we can scale this up in wastewater. We're able to potentially scale it up for purposes of antimicrobial resistance, for foodborne outbreaks and many other things, which we're really looking forward to doing now that we've established this incredible capacity.
Right, great, perfect. Ms. O'Connell,
Senator Marshall?
The American people, my family, all of our families are struggling as this pandemic continues to drag on with no end in sight. The words I hear every day, multiple times each day, continue to resonate and echo in my mind as I sit here. Words like I'm tired, confused, burnout, scared, and frustrated. The list goes on. But what's making the situation worse are the officials leading our nation's COVID response going on national television and contradicting each other. And of course, some Supreme Court justices are spreading misinformation as well. Dr. Walensky, this past week, you recommended asymptomatic people be able to return to work after 5 days. But Dr. Fauci ambiguously corrected you on national television and suggested folks needed a test before return. How does it make you feel when Dr. Fauci or someone like Justice Sotomayor upstages a previous statement or policies of yours, blatantly contradicts and undermines your guidance, or offers false claims that cause more confusion for the American people?
Thank you, Senator. I have the great honor of leading the agency of 12,000 public health servants in this country, and we work collaboratively with tens of thousands of public health officials around the country to provide guidance. I also get to work with a COVID-19 task force that is full of a multidisciplinary group of people with diverse expertise, from immunology to drug regulation to epidemiology. This science is moving really quickly, and I know you will appreciate that it's moving fast and it is changing, and it is our
You're not answering my
responsibility
question,
to convey that science.
So I'll move on.
Thank you. Dr. Walensky, I don't know if anybody's asked this question. I just want to get it cleared up. Our Supreme Court Justice last week, looking into the situation with the mandate, Justice Sotomayor said there's 100,000 children that are sick as we speak with Omicron, and a lot of them are serious in hospital. Is that true or false?
I don't have the number of children in the hospital right now. It's likely less than 100,000.
Yeah, and Justice Breyer said that, that if we continue to delay this ruling, that we're going to have 750,000 more that are not vaccinated infected a day. I mean, does that make sense to you?
What I can tell you is our children between the ages of 0 and 4 are one of the only places where our hospitalization rates are currently rising, and that children who are in the hospital are generally unvaccinated, not uniformly, but generally unvaccinated. And that's true for not just our 0 to 4 who are obviously ineligible, but also true for our 5 to 11-year-olds as well as our 12 to 17-year-olds.
Thank you. Well, thank you all for being here today. Thank you very much. Thank you, Madam Chair.
Thank you so much. I have one. Dr. Walensky?
Yeah, and maybe I'll just pick up exactly where Asper O'Connell has put down. So, you know, our ICAP program, our Increased Community Access to Testing program, does place tests in pharmacies and social vulnerability indices that are high. That's by design. Tests in federally qualified healthcare centers and community centers, just as the Assistant Secretary mentioned. We also continue to support screening tests at no cost to child care centers, K-12 schools, and congregate settings through exactly the program that the Asper mentioned, Operation Expanded Testing. We prioritize high schools that have, and all schools that have high social vulnerability. And we have a website now that's active where you can enroll.
Okay, thank you. Senator Burr, I understand you have two additional questions.
If I could, Madam Chair. This is for Dr. Woodcock and Ms. O'Connell. It's my